Extrauterine Pregnancy audio course. Episode 2, Epidemiology, Risk, and No Risk Factors. The first epidemiologic fact about ectopic pregnancy is simple. It is uncommon in the background population and common enough to kill when the clinical context changes. ACOG places ectopic pregnancy at about 2% of reported pregnancies. Nature Reviews gives the usual range as 1 to 2% of pregnancies. If that is the only number in the resident's mind, the disease can feel rare. But the patient in front of you is not always drawn from the background population. If she presents to an emergency department with first trimester pain, bleeding, or both, ACOG cites a prevalence reported as high as 18%. The symptom doorway changes the denominator. This is worth hearing slowly. 1 to 2% is the background pregnancy number. 18% is not the same population. It is the population already filtered by symptoms, severe enough to bring the patient to emergency care. The disease did not become biologically more common in all pregnancies. The clinical door selected a higher risk group. Whenever a number in ectopic pregnancy sounds contradictory, ask which denominator it belongs to. This is why epidemiology must be taught as conditional probability, not as a single prevalence. A woman with no symptoms in routine early pregnancy care, a woman with pain and bleeding in the emergency department, a woman pregnant with an IUD in place, and a woman pregnant after IVF are not the same probability problem. The pregnancy test is the same. The risk environment is not.
Risk factors are useful because they identify mechanisms. They are dangerous when they are treated as admission criteria for evaluation. NICE explicitly says to exclude ectopic pregnancy even in the absence of risk factors, because about 1/3 of women with ectopic pregnancy have no known risk factors. ACOG makes the warning even stronger. 1/2 of women diagnosed with ectopic pregnancy have no known risk factors. Novak says the same thing clinically. Up to half have no identifiable risk factor, so a high index of suspicion remains necessary. The 1/3 and 1/2 figures are not trivia. They are a guardrail against a very human shortcut. If the resident asks about prior ectopic, PID, tubal surgery, infertility, and IUD use, and all answers are negative, the mind wants to downgrade the diagnosis too far. The guidelines are warning that absence of recognized risk factors is common among real ectopic pregnancies. A clean history lowers suspicion in some settings. It does not erase ectopic pregnancy from a symptomatic early pregnancy. That fact should change history taking. The resident should ask about prior ectopic pregnancy, tubal surgery, pelvic inflammatory disease, infertility, assisted reproduction, endometriosis, smoking, contraception, and IUD use. But if every answer is negative, the diagnosis is not removed. The history modifies probability. It does not close the workup in a symptomatic pregnant patient. Prior ectopic pregnancy is the strongest familial risk marker because it points to a patient and a reproductive tract that have already demonstrated the possibility of abnormal implantation. ACOG gives recurrence of approximately 10% after 1 ectopic pregnancy and more than 25% after 2 or more. Novak gives a similar recurrence range, 10 to 15% after the first ectopic and about 30% after the second. The exact number varies by population and treatment history, but the practical meaning is stable. The next pregnancy needs early location assessment. Anchor the recurrence numbers to the story of the tube. 10% after 1 ectopic is not a random warning label. It reflects that the original problem may still be present. Tubal scarring, ciliary injury, adhesions, prior infection, prior surgery, or an underlying fertility pathway that has not changed. More than 25% after 2 ectopics means the reproductive tract has declared the vulnerability more than once. The numbers should make the next positive pregnancy test an early location event, not an ordinary waiting game.
Tubal injury explains many other risk factors: pelvic inflammatory disease, previous tubal surgery, tubal ligation failure, hydrosalpinx, endometriosis, adhesions, and tubal factor infertility all converge on the same problem: The embryo must move through the tube at the correct time, and the tube must remain a transport organ rather than an implantation bed. If anatomy is distorted, cilia are damaged, muscular transport is impaired, or inflammatory signaling changes the tubal lining, the conceptus may still be in the tube when it becomes capable of implantation. The IUD example is the cleanest way to teach selected risk. An IUD is highly effective contraception, so it lowers the absolute risk of pregnancy and therefore lowers the absolute number of ectopic pregnancies compared with no contraception. That part should be said clearly, because patients should not hear that the IUD was a bad contraceptive choice. The clinical shift happens only after pregnancy has occurred despite the IUD. ACOG states that up to 53% of pregnancies that occur with an IUD in place are ectopic. Novak states the same principle. The overall risk of pregnancy is very low, but the rare pregnancies that occur are more likely to be ectopic. The correct bedside sentence is therefore precise. The IUD made pregnancy unlikely. Now that pregnancy has occurred, we must prove the location.
Repeat the IUD logic in 2 steps. Before conception, the IUD protects strongly because pregnancy is rare. After conception has occurred despite the IUD, the denominator has changed to pregnancies with an IUD in place, and within that selected group, ectopic pregnancy is common enough to demand location proof. This distinction prevents both patient blaming and false reassurance. Assisted reproduction creates a different selected risk problem. ACOG cites naturally conceived heterotopic pregnancy as roughly 1 in 4,000 to 1 in 30,000. But after IVF, the risk may be as high as 1 in 100. Nature Reviews notes that heterotopic pregnancy has become less rare in assisted conception populations than historical spontaneous pregnancy teaching suggested, though modern single embryo transfer has reduced some of that risk. The heterotopic numbers should be remembered as a change in scanning behavior. 1 in many thousands in spontaneous conception means the diagnosis is uncommon, but not impossible. As high as 1 in 100 after IVF means the scan must not stop with the first intrauterine sac. The HCG is not helpful here because the intrauterine pregnancy can produce a normal rise. The discipline is anatomical. Look in the uterus, then still look at the adnexa and pelvis.
The danger is not only that an ectopic pregnancy is more likely, the danger is that the resident may stop too early. In heterotopic pregnancy, a normally sighted pregnancy can be visible in the uterus and can produce a reassuring HCG trajectory. The ectopic pregnancy may be in the adnexa at the same time. After IVF or ovulation induction, a scan that finds one pregnancy has not necessarily answered whether there is only one pregnancy. Ectopic mortality is also a lesson in systems, not only biology. Nature Reviews describes ectopic pregnancy as the leading cause of early pregnancy maternal mortality, with rupture causing intra-abdominal hemorrhage and hemodynamic compromise. It also emphasizes that outcomes are not evenly distributed. In low and middle income settings, delayed diagnosis, limited ultrasound access, restricted treatment options, and loss to follow-up can turn a treatable early diagnosis into late emergency laparotomy and hemorrhagic shock. Even in high-resource settings, mortality reviews repeatedly find delay. Delay in recognizing pregnancy, delay in face-to-face assessment, delay in ultrasound, delay in transfer, or delay in escalation when symptoms change. This should make the resident careful in 2 directions. Do not screen every asymptomatic pregnant patient as if she has ectopic pregnancy. Nature Reviews notes that risk indicators are not strong enough to justify broad screening of symptom-free women because false positives and anxiety become substantial. But do not withhold evaluation from a symptomatic patient because she lacks risk factors. Symptoms, pregnancy status, and access to follow-up matter more than a clean risk factor list. So the clinical behavior is not panic and not reassurance. It is probability management. First, identify the doorway.
routine pregnancy, pain or bleeding, IUD pregnancy, IVF pregnancy, prior ectopic, or unstable presentation. Second, ask whether a mechanism is present: prior tubal injury, inflammatory disease, assisted reproduction, scar anatomy, or contraception failure. Third, decide whether the next step is immediate assessment, early pregnancy unit review, repeat HCG and ultrasound, or emergency escalation. The patient with pain and bleeding is not protected by a low background prevalence. The patient with no risk factors is not protected by the absence of a label in her history. The patient pregnant with an IUD is not experiencing ordinary pregnancy probability. The patient after IVF is not fully reassured by seeing one intrauterine sac. Epidemiology is useful only when it changes the next action. In ectopic pregnancy, it teaches one disciplined habit. Before interpreting a symptom, decide which probability world the patient has entered.